Hello everyone and welcome back to my channel. So today's topic is inflammatory bowel disease, and this is such an important topic for the theory papers as well as for the Neet PG exam or MCQ based exam. So there are two entities here, as you know, Crohn's disease and ulcerative colitis, and they are very important differences. Basically a chart is given in Robbins, which is a very high yielding and a last minute revision topic. So without further ado, let's dive straight into this discussion. Yes, so inflammatory bowel disease is a chronic condition resulting from complex interaction between intestinal microbiota and host immunity in a genetically predisposed individual that leads to inappropriate mucosal immune activation. The two diseases are ulcerative colitis and Crohn's disease. So basically this happens because of some kind of immune dysregulation, right? So this is the chart I was talking about, a very important last minute revision topic for your exams. And now ulcerative colitis will involve only the colon and the rectum, and it is generally limited to the mucosa and the submucosa. All these points that I've highlighted are very important. Crohn's disease, on the other hand, can involve any area of the GI tract, and this has got a frequent ileal involvement. So, colon is also involved, ileum is also involved, but in case of ulcerative colitis, only the colon and the rectum is involved. Now, in Crohn's disease, you have a transmural involvement, but in ulcerative colitis, the involvement is only limited to the mucosa and the submucosa. So, this is again a very important point. This is transmural, but this is not transmural. Okay. As and when I discuss these points, I'm just going to put a tick mark here. We are done with this point that the involvement area is colon only in case of ulcerative colitis, but it is colon and ileum. Basically, it involves almost any part of the GI tract in case of Crohn's disease. And I've also mentioned about the inflammation, which is a transmural in case of Crohn's disease and limited to mucosa in case of UC. Now, what is the pathogenesis? It results from combination of abnormalities in the immune regulation, host microbe interaction, and epithelial barrier functions in genetically susceptible individuals. So, for example, there is a polymorphism of the NOD2, the strongest risk gene for Crohn's disease, associated with a 10-fold increased risk of the disease. So this is not to Crohn's disease. These two are again related important point. The environmental factors are critical to pathogenesis. For example, the mucosal immunity is important. And you must remember here that there is a T1 polarization in both the diseases, but in ulcerative colitis, you only have the T2. So Th1 activation is there in both the diseases, but in case of ulcerative colitis, you only have the Th2 activation. Now Th17 is also important in the IBD pathogenesis, as both the Crohn's disease and the ulcerative colitis are linked to polymorphism in the interleukin 23 receptor and other molecules involved in the Th17 signaling. So this is also important in both the diseases. Okay. Now, the second mechanism is the autophagy and the cellular response. The defects in the autophagy and the cellular stress response can contribute to this pathogenesis. So, basically, we are learning here the different mechanisms by which there is immune dysregulation happening over here. Now, there is these genes which is the ATG16L1 and IRGM, both of which are involved in the autophagosome formation. And this ATG16L1 mutation that is linked to Crohn's disease promotes this degradation, thereby limiting autophagy. And the third mechanism is the host microbial interactions. So soluble microbial products activate the host sensing proteins, including the surface TLRs and dectin receptors, and intracellular microbial associated pattern receptor, which is the NOD2. So basically all these points, there is a dysregulation or a change in the host microbial interaction and the environment. There is limitation of the autophagy and the cellular stress responses, and there is also defect in this mucosal immunity. All of this together will give rise to this kind of abnormality in the immune regulation, and this will result in IBD in genetically susceptible individuals. So here NOD2 is important, and this gene is important. Okay. So now coming to this individual points, very important, talking about the Crohn's disease. As I mentioned, anywhere in the GI tract, but most commonly in the terminal ileum, ileocecal valve. Ileum is basically the most common part which is involved, followed by colon, and this results in skip lesions. So skip lesions is characteristic of Crohn's disease, and it differentiates it from the ulcerative colitis. So what is skip lesions? As you can see in this picture, that some parts of the GIT is involved, but in ulcerative colitis you have continuous involvement. There is no skipation, it's a continuous involvement. If it is beginning somewhere and ending somewhere, the entire segment in between is involved. But here you can see it is involved over here, this part is paired, again here it is involved, okay, and this part is again involved. So this is basically the skipation. And if you see this, there is transmural inflammation and there's ulceration and there's fissures happening, okay. So we are just done with this point that in Crohn's disease you have this skip lesions, right? A very important question. May progress and multiple lesions, they may coalesce to form elongated serpentine ulcers along the axis of the bowel. So all these points are very very important. You may have aphthous ulcer which can ultimately result in formation of serpentine ulcers. Now ulceration with sparing of the interspersed mucosa, as I said, there is skip lesions. Now this will result in an irregular cobblestone appearance of the mucosa. So now because there is kind of a skip lesion, some part involved, some part are not involved, and therefore this will give rise to cobblestone appearance of the mucosa. Fissures frequently develop. The intestinal wall is thickened and rubbery as a consequence of a transmural edema, inflammation, submucosal fibrosis, and hypertrophy of the muscularis propria, all of which will contribute to stricture formation. With extensive transmural disease, the mesenteric adipose tissue frequently extends over the cellular surface, known as the creeping fat. So very very important point. So cobblestone disease and creeping fat are the two most important points that we have learned just now. Okay, so whatever points are not mentioned here, I'm going to put them down together in one table so that it becomes your last minute revision topic. So here in Crohn's disease, we have found two important extra points, and that is number one, the aphthous ulcer. Number two is the cobblestone appearance of the mucosa, and number three is the creeping fat. So let's just mention this down over here. Okay, now continuing with this, the microscopic features of active Crohn's disease include neutrophils that infiltrate and damage the crypt epithelium. So you're going to have a crypt abscesses, because in the crypt you're going to have neutrophils. So this is crypt abscess, and repeated cycles of crypt destruction and regeneration will lead to distortion and disorganization of the mucosal glands. So there's going to be crypt abscess and distortion and disorganization of the mucosal glands. Epithelial metaplasia is another consequence of this. One form known as pseudopyloric metaplasia refers to the presence of gastric antral appearing glands over here. So there is kind of a metaplasia because the gastric antral glands are kind of present over here, which is the unusual place. It should not be present over here, but then it is present, and therefore it is known as pseudopyloric metaplasia. Paneth cell metaplasia may also occur in the left colon, where Paneth cells are normally absent. Now, mucosal atrophy may be there, and non-caseating granuloma is a hallmark of Crohn's disease. So now let's see if we can get these points. So granuloma may, yes, there is granuloma present in the Crohn's disease and absent in this, and this granuloma is basically of the non-caseating type, right? So what are the extra points that we have learned just now? Okay, and now let's talk about this. There is iron deficiency anemia, fibrosing stricture, fistula may be developing. Now extra intestinal manifestations of Crohn's disease include cutaneous nodules formed by granuloma, uveitis, migratory polyarthritis, sacroiliitis, ankylosing spondylitis, erythema nodosum, cutaneous granuloma, and clubbing of the fingertips. So all of which is important. And now let's come back to this chart and see what are the points that is not mentioned. So yes, strictures are present. It is a kind of a rare in case of ulcerative colitis. The wall appearance is thick in case of Crohn's disease. Now, lymphoid reaction is marked, as I mentioned here, fibrosis, serositis, this fistula, ulcer, all these things are predominant in the Crohn's disease. Okay, so lymphoid reaction, fibrosis, serositis, fistula, stricture, all these things are predominant in the Crohn's disease. You have perianal fistula over here, and you also have fat and vitamin malabsorption. So extraintestinal manifestations of ulcerative colitis overlap with those of Crohn's disease and mainly include the migratory polyarthritis, sacroiliitis, ankylosing spondylitis, uveitis, and skin lesions. They also may have primary sclerosing cholangitis. Now it involves the rectum, extends proximally in a continuous fashion to involve part or all of the colon. Therefore, pancolitis can be present. The small intestine is normal, it is not involved, although mild inflammation of this distal ileum may happen, and therefore is known as the backwash ileitis. So backwash ileitis is present in case of ulcerative colitis, and it is also having pancolitis. There is no skip lesions. The involved colonic mucosa may be slightly red or granular, and now there may be pseudopolyps, mucosal bridges, mucosal atrophy. The colon wall is not thickened. So please understand here that the chronic disease may lead to mucosal atrophy with smooth muscle surface that lacks normal folds. So because this is not a transmural disease, there is basically mucosal atrophy over here, and therefore this colon wall is not thickened. The serosal surface is normal and strictures do not occur. Because this is not thickened, therefore there is no stricture. The serosal surface is rather normal. Okay, and you may also have toxic megacolon, which has got a significant risk of perforation. हिस्टोलॉजिकल फीचर्स ऑलमोस्ट ओवरलैप, तो ओवरलैपिंग फीचर्स में ना क्वेश्चंस नहीं होंगे, तो डिफरेंशिएटिंग फीचर्स है उसमें ही क्वेश्चंस होते हैं यूजुअली. In contrast to Crohn's disease, granulomas are not present and the diffuse inflammation is generally limited to the mucosa and the superficial submucosa. I've already mentioned this point here. So now what are the extra points that we found over here? First of all, backwash ileitis and pseudopolyps, mucosal bridges, mucosal atrophy. So here we can see that yes, this pseudopolyps is marked in case of ulcerative colitis. There is backwash ileitis. Serosal surface is not involved. Colon wall is not thickened, and there is yes, toxic megacolon is present over here and not in the Crohn's disease. And very important point, malignant potential is there in ulcerative colitis and not in Crohn's disease. So it may seem that Crohn's disease has so many negative points. There is ulcer, there is fibrosis, serositis, granulomas, fistula, strictures. All of this is happening in the Crohn's disease, the transmural infection, and it seems to be a more severe disease than ulcerative colitis. But ulcerative colitis is even more bad because it has got a malignant potential and it has got the chance of getting converted into a toxic megacolon. Recurrence after surgery is another point. Yes, it is common in case of Crohn's disease, but there is no recurrence after surgery in ulcerative colitis. So these ulcers are deep in case of Crohn's disease because it is transmural involvement, and it is superficial and broad based in case of ulcerative colitis. So almost all the points I have covered. Along with that, I'm also mentioned some important points. Okay, so this is basically your last minute revision chart that you have to remember for your exams. So with this, we come to the end of this topic. I hope you learned something from me today. You enjoyed watching this video, and if you like my content and my effort, then please consider subscribing to my channel to support me. I will meet you very soon in my next episode. So till then, take care, keep studying, and thank you for watching.